It is an honor and a pleasure to introduce this year's keynote speaker, Dr. Megan L. Ranney. Dr. Ranney earned a bachelor's degree in history of science, summa cum laude, from Harvard University, and her medical doctorate, graduating Alpha Omega Alpha from Columbia University. She received a master's degree in public health from Brown University and completed her residency in emergency medicine and a fellowship in injury prevention research at Brown University. She was previously a Peace Corps volunteer in Ivory Coast. Dr. Ranney is a practicing emergency physician, researcher, and a national advocate for innovative approaches to public health. She is the Deputy Dean at the School of Public Health at Brown University, the Warren Alpert Endowed Professor of Emergency Medicine at Alpert Medical School of Brown University, and the founding director of the Brown Lifespan Center for Digital Health. Dr. Ranney's research focuses on developing health interventions to prevent violence and related behavioral health problems, as well as on COVID-related risk reduction. She has had continuous extramural funding from federal and foundation grants for many years. In recognition of the high importance and impact of her work, Dr. Ranney was elected to the National Academy of Medicine. Dr. Ranney has also held multiple national leadership roles, too many to list in this brief introduction. She has received numerous awards for technology innovation, public health, and research. We are extraordinarily fortunate to welcome her as our keynote speaker for this 54th meeting of the American Pediatric Surgical Association. Please welcome Dr. Ranney.
Thank you so much for that kind introduction. It's an absolute honor to be here with all of you who so often serve as my colleagues in the emergency department, talking today about firearm injury as a public health problem. So, as a good academician, I'll start with my disclosures. I do have NIH and CDC research support, and I serve on the board of directors of a few different organizations related to violence prevention. I have no fiduciary, or I have obviously fiduciary responsibilities, but get no money from any of those boards. So last night at the dinner, someone asked me how I started working on firearm injury as a public health problem. And I often start with a story. I think like most emergency physicians, like most surgeons, I saw gunshot wounds as part of the bread and butter of my specialty. Like you, many of us in emergency medicine choose our specialty based on the likelihood of our caring for penetrating trauma. I think it's so important to be good at it that we flock towards the residency programs that have higher numbers of shootings and stabbings. And I just accepted this. Although I had worked on violence prevention around gender-based violence and sexual assault for a very long time, I didn't question the steady flow of gunshot wounds that came through my emergency department many nights. And then one evening in the mid-2000s, very soon after I'd finished my residency, I was a relatively new attending. I was working in our trauma rooms at Rhode Island Hospital, which is our level 1 trauma center in Rhode Island. We got a call over the EMS radio that they were coming in with a GSW. Rhode Island's really teeny, so we knew we only had a couple of minutes to prep, but there was this excitement in the air, right? Because it was July, and so I had a bunch of med students and brand new surgery residents and brand new EM residents who had just risen up to being able to be in the trauma rooms, and there was that buzz of kind of getting the thoracotomy tray and getting the chest tubes ready. And then a few minutes later, EMS rolls in, and they're walking, which is strange. And they roll in the room, and the air completely went out of the room. So we looked at the person on the stretcher, and it was not at all what we had expected. And that was for 3 reasons. The first was that this young man had been shot in the head, and it actually turned out that he had shot himself in the head with his father's service weapon. His dad was part of our local first responder community. The kid had had an emotional episode that day and knew how to access his dad's firearm, and decided in a moment of impulsivity to take his own life. It was at that point the only time that I had ever seen someone shoot themselves. I obviously take care of suicide attempts a lot. I almost always save them. Over the course of my 20 years as an emergency physician, I can count 5 suicide deaths. 3 of those now have been firearm suicides. That was the first one. And so I started questioning with that case, why had I never seen a firearm suicide before? What was different about firearm suicide versus all the other suicide attempts that I can save? And I'll talk a little bit about that. The second part about the case that immediately stood out was that this young man was white. And most of the folks that we take care of who get shot are not white. And that was before we talked about structural racism, right? This was a time where, obviously, as a good social justice person, I talked about racism, but we hadn't called out the fact that we weren't talking about gun violence because of the race and ethnicity of the folks that were getting shot. And that reaction, the fact that I looked around the room and saw that most of us in the room were white, and so was the victim, and the change in the tone has stuck with me to this day and motivates so much of my work on this issue and my determination to not let it kind of sink down in the list of priorities. And the third thing about that case that stuck with me was I was an injury prevention fellowship trained researcher. And if I could stand there and talk about the importance of motorcycle helmets and about the importance of doing screening women for domestic violence and about the importance of us talking about factors that lead to increased risk of sexual assault, why was I not talking about the prevention of gun violence? And as a good emergency physician, I don't take no easily. And so I said, you know what, I'm going to start working on this. There were 3 additional things that really kind of play a big part of my story, though. The first, on the left of the screen, is a picture of a man named J. Dickey. Many of you are, of course, familiar with the Dickey Amendment. In 1996, he was a junior representative from Arkansas, and he passed this so-called Dickey Amendment in the wake of some really great research done by one of my emergency medicine colleagues, Art Kellerman, as well as some folks down at Penn, showing that having a firearm in the home increases the risk of firearm death. Now, that's not a shocker. Having a pool at your home increases your risk of drowning death. Being around cars increases your risk of dying in an MVC. But this, at that point, was taken as a statement on the values of guns. J. Dickey passed this amendment, which, although it did not actually remove funding from the CDC, effectively resulted in the reduction of appropriations to the CDC that were equivalent to how much they currently had to spend on firearm injury prevention research. The letter of the Dickey Amendment was later applied to the NIH. And why I put him up there is because that happened, of course, just a few years before I started working on this issue. And so when I started talking about gun violence as a public health problem, firearm injury as part of injury prevention, I was told by a multitude of mentors, with one exception, who was at University of Michigan, Rebecca Cunningham. I was told by a multitude of mentors not to talk about it because I would doom my career as an academic researcher. So I put J. Dickey up partly because of history. By the end of his life, he actually said he was wrong. We could have done research on firearm injury, but also as a message to those of you in the audience who have your own issues that you're being told not to research, to not take that as the gospel truth. The middle picture, of course, is Sandy Hook and the prior speaker who is from Sandy Hook. My condolences to you and to your community, but that same thing can be said for all the other communities across the United States right now. You know, that was such a turning point for so many of us. I feel that it motivated many of our medical societies to finally speak out about firearm injury as a health problem, but obviously here we are today, just a couple of days after another public mass shooting. Clearly their deaths were not enough. And the third picture is of Dr. Tamara O'Neill, a fellow emergency physician who was shot and killed as she walked out of her emergency department shift at Mercy Hospital in Chicago in 2018, just a week or so after the NRA sent their infamous stay in their lane tweet. Her ex-fiancé found her, knew her shift schedule, and shot her in the parking lot, and then killed a police officer and a pharmacist. And I put her picture up as a reminder of how personal this is, because her story as well motivates me every day. And I know here at APSA that you all, I've heard that Dr. Hirsch last year gave a moving talk about Dr. Wood. I know that you too have personal stories about the way in which this epidemic affects every one of us. So with that as preamble, let me get into the actual facts. So my whole thesis is that firearm injury is an epidemic, and the term epidemic is increasingly used loosely, so I think that it's important to start with a definition. The CDC's official definition of an epidemic is the occurrence of more cases of disease or injury than expected in a given area or among a specific group of people over a particular period of time. So what makes it an epidemic? We fit each part of that definition. So we all obviously experience the fear of mass shootings. I have two kids, a middle schooler and an elementary school kid about to go into high school and middle school. And every day when I put them on the bus, I say a little prayer that they're going to be fine. But the reality is, as every one of us knows, those public mass shootings, as horrific, random, and terrifying as they are really only the tip of the iceberg. Depending on the year, there's 100 plus folks who are killed every day across this country. Last year it was about 150 killed every day, and well over 200 are injured every day. As I'll talk about, we don't know the exact number. Importantly, about 60% of those deaths are suicide related. So although we have a very legitimate fear of those mass shootings, we have to recognize that our epidemic of firearm injury goes far deeper than that. It's an epidemic as well because we all know someone affected by gun violence. Physicians, military, veterans, which make up a large part of my emergency medicine community, and I'm sure part of APSA as well, are at disproportionate risk of suicide by firearm. Kids as well, law enforcement officers, people who come from African heritage are at disproportionate risk. And a recent survey by Kaiser Foundation reports that 19% of us have been personally threatened or shot, 21% of us have a family member who has been threatened or shot, and 54% of us across the United States have either ourselves or a family member had a personal experience with either witnessing being threatened or being shot by a firearm. It's an epidemic as well because it does concentrate in certain areas. I put these slides together before a recent paper last week by Charlie Brannis, but the takeaway from it is the same as this, which is that there are states, as the prior plenary presentation just showed, that have a much higher death rate from firearms than others. And contrary to popular belief, yes, there are some urban areas that are at disproportionate risk, but it is rural states and rural counties that are at the highest risk. New Mexico has a number of the top 10 counties in the country in terms of firearm death rate. Missouri, Louisiana, Arkansas, Alaska, Wyoming also make up that top list. My own state of Rhode Island and the state that I'm about to move to, Connecticut, have been at the bottom in terms of the lowest death rate for quite a while. So this is an epidemic in that it concentrates in certain areas, and I'll talk a little bit more about that. So if it is an epidemic, we need to start with the facts, just as we did for COVID. So I'm knowing that many of you already know this, so I'm going to go through the basics about who dies from firearms in the United States. So this is the pattern of firearm deaths among males. The x-axis is ages in 5-year increments. Y-axis is number of deaths, absolute numbers, not corrected for population. 2021, most recent year that we have full NVSS data. So you see spike in young adult years, what we've all experienced in our training and our practice. That's men, that's women. I'm not going to talk a lot more about females who die of a firearm injury, other than to say that the vast majority of them are intimate partner homicide, like my friend Tamara O'Neill. There are approximately 70 to 75 women who are shot and killed by an intimate partner homicide every month, and I'm sure every one of us has a story of someone we've taken care of in the hospital. If I go deeper into firearm deaths among males, again, x-axis is age, y-axis is absolute numbers. These are firearm deaths among non-Hispanic white males non-Hispanic black males in the dark blue, non-Hispanic white males in teal, and then Hispanic males in the more greenish color. Among those, you can see that there are really a couple of different spikes. Non-Hispanic black males have a huge spike in death rates from about age 15 to 34. that is largely related to homicide. And as I will talk about further, that's largely related to structural racism, historical redlining, economic opportunity. Unfortunately, we're also seeing a rising rate of suicide among young Black males. Among white males, we see that same spike in the young adult years, but then it doesn't drop off. And that's mostly because of suicide. We know that white men, middle-aged, particularly divorced or widowed white men, are at the highest risk of firearm suicide. And about 2/3 of gun deaths nationally are among white men. And then on the bottom are Hispanic males. Again, this is not corrected for population. We do know that young Black men are at approximately 20 times the risk of being shot and killed than young white men. And again, it is largely because of structural factors. To be very clear, there's no race-based risk. It is really around kind of the environment. The last part of why this becomes an epidemic is because death rates are increasing. So here we have suicide, homicide, or legal intervention, which are difficult to distinguish out, and then quote unquote accidental, which of course anyone in injury prevention, including most of you, excuse me, would call unintentional. We saw death rates start to increase in about 2006, largely due to firearm suicide. Homicide rates kind of muddled along at about approximately a baseline level until around 2013, 2014, when they started to go up. And then, as all of us have experienced over the last couple of years, we had a dramatic increase in the rate of firearm homicide during the COVID pandemic. Many cities are starting to see that drop, although we don't have official data yet, so it's still anecdotal. And knowing that I'm here at APSA, I would be remiss to not mention kids. A recent paper in your own Journal of Pediatric Surgery shows that dramatic rise in both firearm homicide starting in about 2015 and in firearm suicide starting in about 2006 in children, as well as across the entire American population. You'll also note at the bottom that there has been an increase in unintentional shooting deaths among kids in the last few years, largely thought to be related to the increasing number of firearms in homes and the decrease in safe storage, which of course leads to guns. So there are about 400 million firearms in private hands in the United States. The average gun owner has 5 firearms. About 40% of households have a firearm in it. Most of those are not stored in the safest way possible. In other words, both locked and unloaded. Of those 400 million guns, there are about 50,000 gun deaths and about another 100,000 gun injuries a year. So it is not a one, and I'll talk about this a little more, but it's not a one-to-one correlation. And the reason that I put this slide up is that demonizing guns and gun owners dooms us to not make progress. So I am not at all lionizing guns. I don't personally own one, but I grew up in a family that had family members who were military, Secret Service, hunters, etc. And I think we need to create a space for that 40% to be part of the solution. And I'll talk a little bit about why. We know that firearm purchasing went up during the pandemic. Among groups that don't typically purchase firearms, we saw surges in firearm purchasing among women, LGBTQ+ identifying individuals, Blacks, Hispanics, young unmarried people, largely thought to be related to fear about societal breakdown. And of course, again, we did see a dramatic increase in injury rates. Firearm injury overtook car crashes for the first time in 2019. For ages 1 through 19, that became even more pronounced during the pandemic. And in 2021, Americans were killed by guns at the highest rate in 30 years. But again, it's not a one-to-one correlation. This lovely paper looked at outlier counties, so looking at kind of rate of firearm ownership according to the best estimates that we have, and then looking at rate of gun death. I loved that plenary presentation looking at the correlation between policies and death rates. There is absolutely a very real correlation there, but there are other factors as well that go into death rates. And so knowing that 40% of households have a firearm, it's on us to figure out what makes some counties high county outliers and some low outliers. In the epidemiology and the discussion of an epidemic, I've talked a lot about deaths. I've not talked about injury. And the reason why is that we have very unreliable injury data. I know that ACS is trying to use the Trauma Quality Improvement Program, to put together more accurate estimates of non-fatal deaths. But there are all kinds of problems with that, including the fact that I don't activate the trauma service for many of the firearm injuries that come through my emergency department. If it's not to the box, if it's not a threatened limb, you guys don't get called. There have been attempts to estimate the number of injuries among different age groups, different race and ethnicity, different geographies, but we have a long way to go in terms of having accurate data, which hurts our ability to accurately prevent it. The last part, as I talk about epidemiology, is to talk about mass shootings. We are seeing an increasing number of mass shootings in the United States, no matter how you define it. Do you define it as 4+ people shot, 4+ people killed? Does it have to happen in a public setting? Does it include domestic violence? Regardless of the way that you define mass shootings, we're seeing a trend up. There is a lot of talk right now about mass shootings being related to mental illness. I'm sure that most of you know this, but I want to say out loud that the mass shootings, there is generally an opportunity to intervene prior. 80% of folks were in a noticeable crisis prior to their shooting. About 2/3 had a history of mental health concerns versus the population average of 50%. So yes, folks who go out and commit a mass shooting are slightly mentally unstable, but not to the degree that if we just fixed mental illness, we would fix mass shootings. 65% had a prior criminal history, and 63% had a prior history of violence. So if we're really looking for risk factors, it's around prior history of violence. And again, depending on how you count mass shootings, 80% of them, used a handgun. I mention this because as physicians, as advocates, it's incumbent on us to start the discussions about firearm injury as a public health problem with the facts. It's so easy in this moment when we are so afraid to resort to emotion. And if we start with this baseline of knowledge, now there are some people who may not care about facts, but the vast majority of Americans do. And if we start with the actual data, it allows us to then begin to make progress. So what kind of progress can we make? And why do I have hope? Well, I have hope, and I believe that we can make progress because of this public health approach. For those of you in the audience who are not familiar with the public health approach, it's really 4 basic steps, the same thing we do over and over again in every aspect of evidence-based medicine. You start by gathering data, the types of stuff that I just talked about, the incidence rates, looking at kind of differences by demographics, trying to identify trends over time. Then you identify risk and protective factors, or risk factors and promotive factors. Again, not labeling populations per se as being higher risk, but all other things being equal, what puts someone at higher risk of being at the wrong end of a firearm? Or better yet, all other things being equal, what helps to protect them? After that, you develop and evaluate interventions. So you say, knowing those risk factors and those protective factors, what can I put in place to decrease risk or to increase protection? You test it to make sure it works. And then once you find what works, you implement it. And then, of course, in an ideal world, you go back around the circle again. I've talked about this with Institute for Healthcare Improvement, and they're like, Megan, that's the same as our PDSA cycle, which is true. So this should be something very familiar to all of us. And the nice thing about this public health approach is it works not just for quality improvement in hospitals, but it also works for epidemics. We have successfully decreased car crash deaths by over 70% since the 1970s, not by taking cars off the road. In fact, there are more cars, there are more millions of miles traveled than ever before, but rather by using those 4 steps. We looked at who was dying and why. We evaluated risk factors, things like the engineering of cars or drinking and driving. We then tested and evaluated interventions ranging from putting in 3-point seatbelts to developing and disseminating ATLS to putting car seats in cars and making sure that families can't leave the hospital with a new baby until they have a car seat properly installed, to, of course, laws around drunk driving, but also bystander interventions around drunk driving, the rise of Uber, which has been shown in the literature to make a difference in terms of drunk driving incidents. We're seeing a slight uptick in car crash deaths, thought to be largely due to texting and driving, as well as to an increase in pedestrian deaths. And we're now using that same four-step approach to address those problems as well. It works. And it doesn't require, again, a demonization of the mechanism, although there are people who we don't allow to drive. And there are certain types of cars that we don't allow on the road. Another epidemic that we have not eliminated but have made a ton of progress on is HIV/AIDS. So of course, HIV wasn't known or didn't exist until the early 1980s. We then saw a dramatic spike in death rates up until the 90s. And since then, we've decreased the death rate by more than 90%. We've done this through basic science, through discovering and making available antiretrovirals. But we've also done it through a lot of other public health steps. I point as an example to Indiana, where they used abstinence-only education and punitive measures for substance users and saw a dramatic spike in the number of HIV cases and AIDS-related deaths. The abstinence-only approach did not work for HIV. They got that HIV small local epidemic under control when they put in syringe exchange programs, distributed condoms, and talked about safer sex and safer behavior. I use that as an example not to say that HIV and firearm injury are at all the same thing, but to make the point that that harm reduction approach, which is a critical part of that four-step public health approach, is critical if we are going to decrease deaths. We can hope for zero, but the reality is that we can't stop people from having sex. We are not stopping people from driving cars. And in a country where 40% of Americans have a firearm in the house, we are not changing that overnight. And so we have to take this four-step approach in a number of different ways and to allow for space for us to think about how to reduce the risk of harm to someone in a family in a house that has a firearm, while also, again, addressing all of those other aspects, including engineering and enforcement. Oh, sorry, if I go back to the prior slide, the red line, of course, is firearms, where we saw a spike in the 80s and 90s, thought to be largely related to drug wars. Death rates then dropped in the late 90s, and as we've already talked about, started to go up again around 2006, and are only rising since then. And I would argue that the reason why is because we have not applied this public health approach. And we haven't applied it, of course, because of that Dickey Amendment, because of funding, because we, as a field, get less than 2% of the funding that one would expect based off of the morbidity and mortality of firearm injury. But we're starting to change this. Many of you were part a few years back of the This Is Our Lane movement, when the NRA did send out that ill-timed tweet about telling us as physicians to stay in our lane, that firearm injury was not our problem. We took to Twitter and to the airwaves with stories about how this is very much our lane. As I started out my talk with a story about it's not just about our clinical practice, it's not just about those acute injuries, it's also about the long-term ripple effects on communities and about the personal effects on ourselves. Thanks to This Is Our Lane, we finally, 2 years after that movement, got the Dickey Amendment clarified and got Congress to appropriate $25 million in funding, 12.5 to NIH, 12.5 to CDC. We got that in 2020, 2021, and 2022. But now what? So we finally gotten some research dollars. It's still a pittance compared to the volume of injuries and deaths that we see every day across the United States. And the research is ongoing. I love research. I will hopefully spend the rest of my career doing research, but it doesn't solve the problems in front of me today. Certainly in the wake of these past couple of months, where it feels like there's not a week that goes by without a series of either random one-off shootings or mass shootings that make the news. Never mind the things that come through our emergency department and our surgical units every day. So I'm going to spend the last 15 or 20 minutes of my talk talking about what you as a society or as individual physicians can do to stem this epidemic, starting with the facts and then going towards action. And as I talk about this, I want to acknowledge that there are so many of you who are already doing so much. I have pictures of just a few of your APSA members who are true leaders in this field and who I'm proud to count as colleagues. And then, of course, our FACS consortium, and I saw Peter over here. It's good to see you, that was created in partnership between a number of different universities 5 years ago to really restart firearm injury research for adolescents and children. So you can talk to any of them for ideas. They're all doing great work at their own universities and hospital systems. But there's actually some things that you can carry out with you today and do in the clinical sphere as well as the non-clinical sphere to help make a difference. So the first thing that you can do is that you can educate yourself, educate your trainees, educate your medical students on how and who to talk about firearm safety with. There are a few, despite the lack of research, there are a few very well-determined risk factors for firearm injury. Obviously, being a prior victim of assault increases your risk dramatically. Having been a prior victim of a gunshot wound increases your risk 300 times. But there are other risk factors as well, which we can and do see in the clinical setting, including depression or suicidal thoughts, history of domestic violence, substance use, and dementia. Be aware of those risk factors and know that those are populations where it is indicated to screen, to ask about firearm access, and to consider counseling on safer storage. There are ongoing studies looking at the value of universal screening that has not yet been validated, although many of us are putting in place. Know, once you ask about firearm access, how to counsel and give basically a brief intervention. Know how to talk to someone who tells you that they're a victim of domestic violence about the value of getting the firearm out of the house. Because, again, the most common reason for a person to die of domestic violence homicide is a firearm. And know how to link them to domestic violence resources to help them create a safety plan. As a pediatric surgeon, if you are taking care of a family and there's an unintentional injury, you ask them about firearm access in the home. Know how to counsel them on how to keep that firearm out of their kid's hands. They will doubtless say that the firearm is stored in a way that their kid does not know where to find it. And so I remind them that I don't know about their kids, but my kids always find the birthday presents. And I can guarantee that their kids know where the firearm is. Remind them that even if they trust their kid to not touch the gun, I bet that their kid has friends who they don't trust. And they need to have that firearm locked up and inaccessible because of their kid's friends, which often resonates more than kind of implying that the kid themselves is in trouble. And know what to do if you think that someone is tremendously high risk. I'll talk a little bit about extreme risk protection orders, but 19 of our states have ERPOs in place. In most of our states, physicians cannot utilize them. In most states, it has to be law enforcement officers. But go back home, research whether you have an ERPO, and think about how to use it. The picture up here is of a training program called Bullet Points, which was created by one of my friends and colleagues at University of California, Davis, Garen Wintemute, along with Amy Barnhorst, who's a psychiatrist. It is a wonderful online program for those who want to learn more about these screening and brief interventions. For those of you in California, this type of training is now available for all medical students, and we need to do more because so few of us learned about this during our training. So that's the first very basic thing. It's going to have an individual level impact. It's not going to be huge, but it's better than nothing. And it's a place that you can make a difference today. The second place that you can make a difference as pediatric surgeons is getting involved with violence intervention programs. I already mentioned that having been in a fight or having been a prior victim of penetrating trauma is one of the greatest markers of risk for future death from a firearm. We know that that risk is because kids and young adults get caught in a cycle of violence. We also know that that cycle of violence can be broken. This is a picture of the Life Outside of Violence program in St. Louis. I'll also highlight the BHC Collaborative at University of Chicago, which is specifically focused on kids under age 18 who are victims of penetrating trauma, which is, to my knowledge, the only pediatric-only focused program in the country. These provide wraparound programs where it's not just child life services when you're in the hospital, but it's legal help, it's help with education, substance use treatment, mental health treatment, not just for the kid or for the victim, but also for their family, and sometimes can even involve relocation services. I was just actually out at University of Chicago with the BHC Collaborative, and they told a just lovely story about a family who was so high risk for being victimized again that they moved them across state lines to Indiana. So these violence intervention programs can make a tremendous difference. There is an organization called the HAVI for those who are interested in learning more and trying to work on setting up violence intervention programs in your own hospital system. The third thing that you can do is to go a little deeper for those patients who are suicidal. I don't need to tell you about the rising mental health epidemic among young adults in this country, nor the rising numbers of suicide deaths, which predated COVID, but which is only getting worse. Easy access to a firearm, again, increases the likelihood that that suicide attempt will be fatal. 90% of suicide attempts with a gun are fatal versus only 10% of all others. So programs like Lock to Live, which is currently being tested in studies in California and in Colorado, can serve as guidance. We as physicians often don't know what to say or how to say it. So a number of folks, this is created by Emmy Betts, have created online programs to help counsel patients and parents on how to reduce access to a firearm for that period of time where a person is highest risk for suicide death. There are also programs that encourage safe storage in other ways. As members of communities, we know that there are a lot of parents and grandparents that have firearms in the house that need to be gotten out of the house when grandkids or friends and family members come to visit. Safe storage can be expensive, and so there's a group of researchers across the country that are putting together maps of places where you can safely take your firearm, leave it for a little bit, and then get it back, no judgment asked. So it's a way to, again, provide that harm reduction for families or individuals who may not otherwise be open to counseling about how to reduce firearm risk. There's work that you can start to do upstream as well. So there's a lot that we can do about kind of that imminent moment of danger, but there is upstream work. These are pictures of some of the projects that we have ongoing in my research lab at Brown, soon to be at Yale. And there's others across the country as well that are doing interventions for kids who have a history of exposure to violence, a history of exposure to cyberbullying, who have a history of depressive symptoms or aggression, which often intersect. There are ways to change conflict resolution skills, to provide cognitive and behavioral skills, not relying on us as physicians to provide the counseling, but again, rather using technology to reduce the likelihood that they are going to end up in our emergency departments and surgical units down the road. And goodness knows, our kids right now rely on technology far more than they rely on us for that type of advice. Moving even further upstream, there are projects that we can do in communities. This is a project that I'm honored to be part of. There are similar studies that are ongoing in Michigan, working with youth in communities with high rates of firearm ownership to help increase awareness of risk factors and the ability to identify someone who's at risk and to intervene. Just as I talk about us as clinicians knowing about risk factors, kids know which of their friends are at high risk. Not to put it all on them, which is an important part of the training. It's not their fault if someone hurts themselves or someone else. But we have, anecdotally, prevented a number of school shootings across the country by training kids in awareness of risk factors and having a guidance counselor in the school who they can go to and then activate a red flag law or kind of take other actions. There is story after story about workplace shooting that has been averted due to awareness of some of those risk factors. So we're working with teens and parents with 4-H shooting sports to try to increase that awareness and reduce the risk of harm. Stay tuned as to whether it works or not. But another kind of example of going upstream if you're interested in getting outside of the hospital to do this work. And I'll say here, particularly if you are someone who owns firearms or comes from a firearm owning a community with high rates of firearm ownership, doing this work outside of the hospital with community groups matters so much. There's study after study that shows that trusted messengers for firearm injury prevention counseling do not, by and large, include physicians. It's gun shop owners, it's law enforcement officers, depending on your community, it's pastors, it's, again, depending on your community, military. And so thinking about who are those trusted messengers in the community in which you live is just critical. Moving even further upstream in the public health approach is changing the environment. One of my colleagues at University of Pennsylvania, a physician named Gina South, has done some really groundbreaking research looking at the efficacy of putting gardens into vacant lots in Philadelphia, Detroit, and elsewhere, and has also looked at rehabbing abandoned buildings, and has shown that in neighborhoods that are randomized to these gardens or rehabbing versus in neighborhoods that are left to their own devices, the ones where greening occurs have a significantly lower rate of crime, stress and depression, and gunshots. This is perhaps one of the most impactful public health interventions that we can do. And I'll talk about policy, but given the challenges that we have right now around policy in the United States, as well as, again, that historical legacy that we must confront if we are going to overcome this epidemic, that historical legacy and ongoing history of racism, making sure that we invest in communities that have been traditionally disinvested from can have a tremendous impact on those patterns of gun violence that we see every day, as well as the ripple effects that happen from them. All right, so how about policy? Again, I feel like I don't need to show this slide after the plenary presentation, but there are policies that make a big difference. There are some laws that have been shown to reduce rates of gun death. There are also laws that deserve our attention that have been shown to increase rates of gun death, particularly stand your ground laws and increased access to concealed carry licenses without permits. There are states with strong policies in place which have lower rates of firearm injury and death. There are other states that have weak policies in place that have higher rates of firearm injury and death. We, as advocates, can talk about the importance of those policies and can work with our local legislatures to get good laws passed. However, I recognize that not all of us live in a state where that's possible currently, although we can work on it and it takes time. And with the recent Bruin Supreme Court decision, unfortunately, even many of these most evidence-based policies are being overturned. There was recently a Fifth Circuit decision that overturned restrictions on people who had been convicted of domestic violence being forbidden from owning firearms. You can't get to a more evidence-based policy than that. Again, if you go back to my many slides ago, one of the biggest risk factors for being a mass shooter is a prior history of violence or being a perpetrator of domestic violence. And yet, in the wake of the Bruin Supreme Court decision, it's being claimed that domestic violence wasn't a thing at the time of the Constitution, and therefore laws restricting access to firearms for people who have been convicted of domestic violence should also not stand. So I will talk about policies, but I will also acknowledge that if we hang our hat entirely on policies, we are going to miss the boat. Moreover, even when we pass policies, a policy alone is not sufficient, or legislation alone is not sufficient. We also have to enforce it. I can talk about texting and driving and the fact that most of us have states where texting and driving is illegal, and yet how often do you drive down the road and see someone with their phone in front of them? But I can also talk about, in the firearm realm, things like red flag laws. This was an analysis done by the Trace, which for anyone who's interested in this issue is an absolutely outstanding newsletter around firearm injury-related research and data. And after the Q-Bar shooting, they looked, so Colorado has a red flag law in place, and you can see that in Denver County versus in El Paso County, the dramatic difference in the number of petitions and final granted risk protection orders, despite the fact that they have the same laws. So the point here is that if you do live in a state with legislation that is protective, you still need to make sure that it is enforced appropriately and that people are aware of it. And this is a place where we can have tremendous impact without ever going before our legislature. Lastly, of course, we can advocate for funding and for data. My epidemiology of firearm injury portion of this talk was so thin compared to the discussion of epidemiology of any other injury or disease entity. And that's because we haven't had the data and we haven't had the funding. It is on all of us as people who know the value of data, who know the value of that four-part public health approach, to continue to talk to Congress about why funding matters. And we do it because of the stories. It is on us to take each of these steps, not because firearm injury is bad in and of itself, but because firearm injury is a health problem. We see the impact of bullet wounds on our patients. We see the ripple effect of those bullet wounds on their families and on their communities. And we know personally, so many of us, the impact that a gunshot wound has on ourselves. So to close, if you remember nothing else from this talk, my first hope for you is that you learn the facts. You learn the fact that suicides are more common than homicides and that mass shootings are just the tip of the epidemic. You learn the fact that being a young Black or brown man puts you at disproportionate risk of firearm death, not because of the color of your skin, but because of structural racism and the historical disinvestment in the community around you. You learn the facts around the fact that domestic violence is the leading cause of death for women and homicide in the United States, and that most of that is because of a firearm. And you learn the facts that rural counties are not immune. This is not an urban problem. This is an all of us problem. Second, you tell your story. You tell your story clinically, while kind of watching out for HIPAA, but you also tell your personal stories, the way in which caring for these patients has changed you forever, the way in which you may have family members who have died of firearm suicide or homicide. Those stories have tremendous, tremendous impact. And third, I hope that you take action, whether it is just asking those highest risk patients in your clinic about access to a firearm and counseling them that keeping it locked up and unloaded is going to be safer, or whether it's getting involved in creating programs within your hospital system, going before your legislature, or working within your community in partnership with those whose lives have been forever changed by firearm injury. You can make a difference, and I will say the more of us that do this work, the higher our chance of putting a dent in this epidemic. So I will close there. I thank you very much for the opportunity to give the keynote, and I welcome questions. So thank you. Take care. Thank you. Jessica, I'll look to you, but I think we have about 10 minutes for questions. Is that right? Great.
Hi, Megan.
Hi, Peter.
Thank you very much for coming and talking today. You know, this is a uniquely American problem.
Mm-hmm.
And what I didn't hear about from your talk is we have what I call peer countries where the gun ownership is high. And you don't, and I don't know the suicide risks in Australia from gun violence, but they just don't have the problems that we do. You know, can we learn something from what goes on in those countries and bring it here to help us?
It's a great question. Thank you. Yeah, no, I did not make international comparisons here. Our gun ownership rate is an order of magnitude higher than any other OECD country. And our gun death rate is proportionally higher. You can actually kind of track, and there have been both papers and popular press articles kind of looking linearly at the rate of gun ownership versus the rate of gun death. So let's be clear that having a firearm in the home does increase your risk of gun death. That said, there are countries with relatively high rates of firearm ownership that have relatively lower rates of firearm death. And in some ways, it's similar to that slide that I put up about specific counties where there really is not a one-to-one correlation. And that is largely around recognition of risk factors, stricter permitting. So some countries will make people go in for an interview, have to show that you can shoot safely, understand that you shouldn't drink and shoot, right? Here, and I live in Rhode Island, which has relatively strict laws. You take a 10-question quiz, which the gun shop owner, and I've done the quiz, like, you can kind of ask them if you're not sure about the answer. So it's not like a driver's license quiz. You do a 10-question quiz, and that's it. There's no testing of your kind of ability to handle a firearm. There's no mandated training in how to clean or disassemble or safely store your firearm. We've got none of that. And so that's what some countries with lower rates of firearm death do. The other thing is that some countries have put in place specific policies to reduce the risk of firearm suicide. So in Israel, for example, when they had a dramatic increase in the number of suicides among Israeli military members, they put in place a restriction on taking your firearm home over the weekend. So you had to leave it on base, and that resulted in a consequent decrease in suicide deaths. So there are some very specific policies that have been put in place to reduce the risk of specific kinds of firearm death. But at the end of the day, we're really kind of incomparable to any peer country in terms of both our rate of firearm ownership, but also our rate of gun death, unfortunately. Thank you.
This is a virtual question that came through. Limiting gun ownership seems like the obvious solution to some of the current issues. What are some of the potential unforeseen negative consequences that might be anticipated? Thank you.
Great question. I think that the biggest, not unforeseen, but very foreseeable consequence is, again, that 40% of America has a firearm. And so we would have to see a tremendous cultural normative shift if we were going to talk about limiting that. I think we are reaching, so there's a few different parts here. One is that firearm ownership has been part of the history of the United States. The Second Amendment does exist. Firearm ownership is likely going to exist in the United States for as long as the United States is around. There is an extremist position around the interpretation of the Second Amendment, which implies that anyone, anywhere, anytime should be able to own a firearm. There is a normative shift that is occurring, understanding that things like background checks and permitting to purchase do make a difference. That is a way to, in my close work with firearm owner groups, they'll say, it's not the gun, it's the person behind the gun. So then we have to make sure that the person behind the gun is safe to handle a firearm. And so that shift is a way for us to start to make progress. There is a lot of work in the firearm owning community and a lot of particularly online statements, but also some debatable research suggesting that firearms also reduce risk for firearm owners by protecting them. And whether I am working with my Nonviolence Institute in Providence, young men who have largely been victims of violence, and talk to them about their reasons for firearm ownership, or whether I am working with rural white men who are at high risk of firearm suicide, and I talk to them about their reasons for firearm ownership, for all of them, it is about fear. It is the belief that you need a gun to protect yourself. And I will say that for many of those folks, it is true. If you are someone who lives 3 hours from police or fire, and you're worried about a bear or a coyote, you absolutely do need a firearm to protect yourself in that setting. If you are a young man where every other young man on the street, or you think every other young man on the street has a firearm in their pocket, it serves as a marker to help, at least theoretically, protect you. And so an awareness of what those reasons are and making sure that we address those fears around self-protection is critical if we're going to change this. We saw that spike in firearm purchasing during COVID because people were afraid. I mean, I think probably most of us right now are afraid. Garen recently did a study looking at the percentage of us that think there's going to be a civil war. And that's somewhere around 15% of Americans think there's an imminent civil war. I was talking to a friend in New York City, a gay man who tells me that there is now an LGBTQ plus shooting club that meets at Hudson Yards, because folks say, if I don't know how to handle a firearm, how am I going to protect myself when society falls apart? I'm going to be the first target. And I think that we have to acknowledge that fear. We don't have accurate measures of defensive gun use. I will say the same percentage of people in that Kaiser Foundation survey, the same percentage of people said they had used a gun defensively as said that they had personally been shot, not threatened, but shot. And so awareness of that is critically important. And I think awareness of that very real fear among gun owners of that consequence of restricting gun ownership has to be part of the discussion. At the same time, so we can acknowledge that, we can talk about addressing that fear, we can also talk about there are some people who have shown that they are not reliable or safe people to own a firearm. Again, and I can go for these very basic categories like being someone who's had a conviction for domestic violence.
Hi, Megan. Brendan Campbell.
Hi, Brendan. How are you? Your picture was up there too.
I know.
I'm sorry, I didn't see you in the audience. It's good to see you.
So wonderful talk as always. But I do have one question sort of coming from surgeons. So when we surveyed the American College of Surgeons, we found that 42% of us are firearm owners.
Yep.
And nearly 1/3 store our firearms loaded and unsecured.
Yep.
Any pointers on how we can encourage our own to store our firearms more safely?
I feel like I should ask you. Well, I mean, I think it is this discussion about personal safety, right? You know this as well as I do, that the reason that we store our firearms loaded and unsecured and not locked up is because we want to have access to them quickly, because that's the whole reason we have them, right? And so it becomes a question of how do you provide biometric safes that reassure people that they can access their firearm quickly should they need it. It's talking about, again, that risk to your kids or your loved one. It's moving from facts to stories as well. I think that we can all talk about the stats all day long, but it's, oh, well, my grandma lived until 102, even though she smoked, right? And so you may be perfectly safe with an loaded and unlocked firearm, but your neighbor might not be. And so sharing those stories, again, that thing about maybe it's not your kid, it's your kid's friend, can also help. But I also think we have to get, again, to that root cause of why we are storing our firearms unlocked and loaded. We're not going to move the needle until we talk about that. But I welcome your input too, because you're doing some really great work in this area.
Well, but I think what was great that you pointed out is the critical importance of engaging firearm owners in the community, and the 4-H collaborations that you have, and highlighting the work that Emmy Betts is doing in Colorado is absolutely critical to this. So thank you again.
Well, and thank you for your leadership with COT. It's been terrific.
David Rothstein, Seattle Children's. Do you have any updates on, we're in Florida, I don't know if it's still standing, the law that prevents pediatricians from asking kids or about firearm safety? Any updates on what that is? Thanks.
Great question. It is not a law in this state, nor in any state across the country. There was very briefly a law in place that forbid physicians from asking about firearms. However, even in that law, there was a clause that allowed us to ask if we thought someone was at high risk. So dementia, being a child, being a victim of domestic violence, et cetera, we could still theoretically ask. No one tested it. But that law was overturned. Other states have tried to pass similar restrictive laws on the physician-patient conversation, and thank goodness those have not passed. So as of right now, there are no federal or state restrictions on our ability to have that conversation. There are restrictions on maintenance of a database about firearm owners that were put into the ACA, but those don't stop us from asking and from documenting. Hi,
Megan, hi. Thank you for the wonderful talk. So I know you and I speak quite a bit about the intersection between mental health and gun violence, and I'm glad you brought that up. There's an increasing dialogue that we've all here been a part of about profiling at-risk folks, people who are in crisis, as you mentioned. There's obviously a slippery slope there, and that's a difficult thing to do because, as you mentioned, a lot of these people who are in crisis don't have a mental health diagnosis per se. So how do we navigate that, particularly in our evolving world with social media and tech? This is a top-of-mind concern. I know it's a difficult question.
I love it, and I look forward to working on evidence-based answers. I will offer non-evidence-based best practice answers in terms of kind of my grade of evidence to my answer to your question. But I'll actually do it by citing some evidence. So there's a program in Chicago called the READI program, R-E-A-D-I, that is run partly out of the University of Chicago Crime Lab. A woman named Rosanna Anders, A-N-D-E-R-S, runs it. And she has created a predictive model for who is the very highest risk of being involved in a shooting in Chicago. So just for those who are not from Chicago, there are a few neighborhoods that have unbelievably high rates of firearm injury and death. Chicago as a whole is not actually one of the higher risk, or kind of one of the areas with higher rates of firearm death, but there are a few neighborhoods where this risk is concentrated. The number of people in those neighborhoods is much greater than the amount of social services or intervention services that are available. So she and her team have created a predictive model using various data sources, including social media, which I didn't even talk about other than that one slide, but social media is a huge driver of the day-to-day community violence that we see. People kind of post beefs, post challenges to each other on social media, post videos of other people's funerals. It's a whole thing that we've got to get under control. But so Rosanna created this predictive model, but then uses the predictive model in conjunction with violence intervention specialists. So it is not a purely predictive model, it is a predictive model plus a human aspect. Similarly, there's a whole field of psychiatry called forensic psychiatry that has a threat assessment protocol that is relatively well evidenced, has a decent amount of evidence behind it, where again, it's this idea that you identify someone who you're worried is higher risk, and then there's a protocol to go through to determine, are they actually high risk or not? We don't have enough folks that are trained in threat assessments. It's certainly not part of every school system at this point, but there are protocols out there that can be used to combine that awareness of the social media footprint or of other data-driven risk factors with an individual level discussion and assessment. Sure.
Megan, Brian Gilchrist, Brooklyn. I'm going to ask you a more difficult question.
Please.
Your work and Mike Hirsch's work has been magnificent. We all tip our hats to you. But you never seem to address a fundamental issue, which is lack of fathers in males' homes. Among the blacks and among the poor whites, we all take care of every day and night, there's no father figures. And we wonder about why you're not putting money into messengers to the black Baptist churches, to the ministers, to organizations that might get men to stay home and take care of their kids.
I appreciate this question. I'll say it's a personal one. My husband grew up without involvement of his father, so it is something that I spend a lot of time thinking about. I will say, to me, it's more than fathers, it's community, and there's actually great evidence that community involvement protects kids from violence, as well as a host of other health risk factors. Things like Big Brothers, Big Sisters, things like church groups, things like 4-H play a huge role in terms of children's ability to develop successfully, not looking purely at their peer group as the arbiter of appropriate behavior, but rather having a trusted adult that they can go to makes a tremendous difference. And so in much of my writing and my work, one of the reasons that I work with 4-H is actually that belief in that value of community groups. There are many pastors across the country, and there is actually tremendous involvement of faith groups in violence prevention, and I would encourage us to partner closely with them. I will say, though, again, having a husband whose father was not part of his life, you can grow up as a great person not having a dad. It depends on the larger community around you.
Megan,
Yes.
Dr. Rainey, thank you so
Thank
much
you.
for your tremendous presentation. As someone who works at the grassroots level, I just really can't sit and not respond to the last comment. I think we underappreciate the impact of structural racism on communities and the abilities of fathers to have jobs or be present in the home. And I think that the recent work by Angus Deaton and his wife Ann Case at Princeton on deaths of despair, which talk about the increased suicide rate in middle white America, working class white America, and the decreased marriage rate. In the most recent book, The Power of Hope, which talks about the extension of this to the inner city. I think, Dr. Gilchrist, you want to really go deeper in understanding why there are not fathers in the homes, whether it's in white America, and I think we have to address the structural violence, which goes way deeper than APSA, but I think it has to be emphasized in these talks, that important role of disruption of families and communities leading to violence.
I'm gonna
And I think we'll do a quick response, and then I think we are at time. I don't want to take any time away from all the other great presenters who have things ahead of them today. So, do you want to do a very, yeah.
As somebody who takes care of only poor black children every day of my life, I want to say this. President Obama brought up this, our magnificent president. After Sandy Hook, we had a Democratic president, a Congress, and a Senate, and nothing really got done after that. And I think it's an important consideration for all of us to consider that we need to look after each other no matter what your background is.
Thank you. A beautiful note to end this on, because if we do all look after each other, we will slowly but surely get rid of this. So thank you. Thank you all for your work every day. I appreciate it.
So I just want to iterate our communal thanks to Dr. Rani for a fantastic talk, which stemmed from the community roots of violence to planting trees, and I think has given us all a lot to think about at what we can individually do, which is really important if we are to avoid personal discouragement. So I thank you personally for this and from all of us. Just say again, we're so fortunate to have had you here as our keynote speaker to start us off on thinking actively about what we can contribute to the care of children with surgical disorders going forward.